Welcome to today's Calculating MSPB conference call. I will now turn the call over to Sarah Brinkman. Sarah, you may begin.
Thank you. Hello, everyone, and welcome to our webinar, Understanding the MSPB Measure, the first in our series of 3 webinars focused on Medicare spending per beneficiary. We are really glad that you joined us today. My name is Sarah Brinkman, and I am a program manager at Stratus Health, a partner in the Lake Superior Quality Innovation Network. Lake Superior Quinn works with healthcare providers across Michigan, Minnesota, and Wisconsin to improve quality of care and outcomes for patients in our region. I'm joined today by my colleague, Eric Sable. Eric is an epidemiologist at Stratus Health. He holds a PhD in toxicology from the University of Wisconsin and a master's of public health and environmental epidemiology from the University of Minnesota. At Stratus Health, he works across a wide range of quality improvement projects, including supporting hospital quality reporting. Before we jump in, let's just address a few housekeeping items. For those of you who registered before today, you should have received a reminder this morning, including a link to the webinar event page, where you can find the handouts for today's presentation. We'll be posting that link in the chat box as well. A recording of today's webinar will be made available in a couple of weeks, and you'll be able to find a direct link to that recording from that same event page. We encourage you to ask questions throughout the presentation utilizing the chat function on the webinar. We will address your questions at the end and open up the lines for folks to question or comment over the phone as well. Finally, when you close out of today's webinar, you'll be automatically redirected to a short evaluation. We greatly appreciate you taking a few minutes to provide us feedback, which we will use to inform the remainder of this webinar series, as well as future educational offerings. As mentioned, this is the first in a series of 3-part webinars over the course of the summer that will focus on Medicare spending per beneficiary. Today, we will lay the groundwork for understanding the Medicare spending per beneficiary measure, and then we'll move forward on July 18th. We'll dig into some regional data analysis to identify some of the most frequent drivers of Medicare spending per beneficiary in order to better understand what hospitals and healthcare systems should focus on in order to improve in performance. And finally, on August 22nd, we'll discuss quality improvement strategies to impact those primary drivers of MSPB, considering the roles of various settings of care. Here are the objectives for today's webinar. We're going to focus on understanding how the Medicare spending per beneficiary measure fits into the larger hospital value-based purchasing program, learn about the data that's used to calculate the MSPB score, and understand the factors that influence the MSPB measure in the context of an MSPB timeline. So first, at a high level, let's define what we're talking about. The Medicare spending per beneficiary, or MSPB measure, is a way to evaluate hospitals on their efficiency with regards to Medicare spending. And this is done by comparing an individual hospital's spending to other hospitals. When we're talking about quality measures, it's always important to identify whether we're looking for high or low scores as an indicator of performance. In the case of MSPB, lower scores represent greater efficiency. When we talk about MSPB, it's important to recognize that this particular measure is perhaps best understood in the context of the hospital value-based purchasing program. And this is because while MSPB focuses on efficiency and cost reduction, it's just one measure of a broader program that also considers quality outcomes in the form of clinical care, safety, and patient engagement. So we're not just talking about decreasing costs, we're talking about decreasing costs while maintaining positive outcomes. This screenshot shows a breakdown of the various value-based purchasing domains and their measure makeup for fiscal year 2019. You may be familiar with our value-based purchasing fact sheet, and you can find this resource, which has additional information in it as well, on the Lake Superior Quinn website, which is provided on the screen. If we focus in specifically on the MSPB measure within VBP, it was first introduced as a measure in fiscal year 2015 as the sole measure in the domain efficiency and cost reduction. And in fiscal year 2019, the efficiency and cost reduction domain accounts for 25% of a hospital's total performance score. So it's certainly something that hospitals are wanting to focus on as they look at trying to improve their value-based purchasing score. Before I hand things over to Eric, we just really quickly want to review what are we talking about when we look at an MSPB episode. So let's break this down a bit. When we think about an MSPB episode, we have an admission to a hospital, and then there's the discharge from the hospital. And that period of time from admission to discharge is known as the index admission. We're also talking about what happened 3 days prior to that index admission. So any care that was provided prior to admission 3 days ahead of time that was charged to Medicare, and then 30 days post-admission. And when we put all of that together, that's what is encompassed in an MSPB episode. Eric is going to walk us through the MSPB calculation steps, which are outlined here. So we'll be identifying what is included as an MSPB episode and the claims that are included in those, calculating what a standard episode spending is, calculating what the truncated predicted episode spending is using risk adjustment, excluding extreme outliers, high and low cost outliers, calculating the MSPB amount and ratio for each hospital, and reporting the MSPB measure for appropriate hospitals. And Eric, I'll turn things over to you.
Okay, well, thank you. Thanks. And as Sarah said, my name is Eric Zabel, and I'm an epidemiologist here at Stratus Health. And I'll be taking us through some more detailed look at all these different steps, and then we'll be going through an actual example. But just for briefly before I started, I just wanted to mention that you will notice that I sometimes stutter when I'm speaking. So if you are hearing a pause on your phone, it probably might be that. It might not be anything wrong with our phones. So let's get started here. We're going to start with step number 1, which is to identify the MSPB episodes, then claims. The goal of doing this step is to establish the individual hospital's population of beneficiaries that will be used for the MSPB calculation. The second goal is to establish that hospital's full set of data for calculating their standardized spending, and then to exclude any claims and episodes that are not appropriate for the spending calculation or that may have an undue influence. So we'll start with looking at what's the population of beneficiaries here. So we will include only those who have been continuously enrolled in Medicare Part A and Part B for the full period of 90 days prior to the start of the episode until 30 days after the discharge. And as Sarah had shown before, since the episode starts 3 days before the index admission, that means that they have to be continuously rolled 93 days before the index admission through the 30 days post. And we only will include beneficiaries who are admitted to subsection D hospitals, those who are covered by the Railroad Retirement Board, and those for hospitals that are participating in the Medicare acute care episodes. Demonstration. And now we'll talk about some populations that we don't include. And we won't include any episodes where during the 90 days before the start of the episode that the beneficiary was enrolled in Medicare Advantage or had Medicare as a secondary payer. We also exclude any beneficiaries who died. So the hospitals that are not the subsection D hospitals won't be considered for an index admission and therefore are not eligible to start an MSPB episode. However, any subsequent admissions to these hospitals after an index admission to an eligible hospital will count towards that episode spending. And here you can see we have the list of the non-subsection D hospitals, which are the psychiatric hospitals, rehab hospitals, children's hospitals, long-term care hospitals, cancer hospitals, the VA, and critical access hospitals. And one other consideration for the payments that are included is that for any beneficiaries whose primary insurance becomes Medicaid during the episode because they've exhausted their Part A benefits, only the Medicare Part A and B payments will count. So as Sarah had briefly shown before, this all revolves around the index admission. Let's see. And what we want to look at here is the non-index admissions, or those that won't count to start an episode. And that would be any acute hospital to other acute care hospital transfers. And in this instance, neither of these two hospitals will have an index admission or an associated MSPB episode for those hospitals' stays. Secondly, we do not include any episodes where the index admission has a $0 payment, and we won't include any admissions where the discharge date is fewer than 30 days before the end of the performance period. And this is done because those episodes would not have had the full run-out time. So we also won't have an index admission for the hospital stays that are within 30 days of a discharge from another index admission. Hospital transfers to an excluded hospital that does happen during that 30-day window after the index admission will count towards the cost of care, although these obviously can't be a starting index admission. So now we've figured out which of these episodes will be included. Now we want to figure out which are the claims that will be counted. And so the claims have to have a from date or the start date of that claim that falls between 3 days prior to the index admission to just 30 days post-hospital discharge. But there's a very important part of this that I want to mention, is that the claim start date has to begin before the end of that 30 days post-admission time, but the claim end date may go on past the actual end of the episode. And a prime example of that will be a beneficiary who was referred to home health care, so that as long as the start date of that home health care claim was within 30 days post-hospital stay, that full claim cost will count, even if the services for that home health service went past the episode end. Now we'll be on to the second step, and in this one we are going to calculate the hospital's standardized spending for each episode. And here we are trying to capture the differences between hospitals and the use of resources, and to try to remove any sources of variation that aren't directly related to the patient's care. And so one of the prime goals of doing this standardization is to take out any adjustments that are made to national payment amounts that are reflecting the differences in labor costs or other practice expenses that are due to geographic regions. This standardization also will substitute a national standardized amount in the case of services that are paid on state fee schedules, and it will take out from the standardized payment any of the extra payments that are made to hospitals for larger program goals, such as the graduate indirect medical education and the disproportionate share payments and any other payments that are associated with the incentive programs. So the main goal of this standardization, though, is to try to maintain the differences that do exist in the actual hospital payments that result from the choice of a setting that the service is provided in, the choice of who provides it, the choice as to whether multiple services are bundled, and any differences in the providers in how they handle the outliers. So to actually calculate the standardized episodes spending, this is simply the sum of the Medicare Part A and B payments made during the MSPB episode, and it does include the patient deductibles and their co-insurance. And you can see the simple graphic here. This shows that it's the core cost plus any add-ons and any outlier payments. Third step that we'll talk about is to perform risk adjustment to define the truncated predicted episodes spending. And the goals here are to take into account each hospital's mix of different cases. And this will use a look back 90 days before the start of the episode to determine the risk factors of each beneficiary to see how these predicted spending costs should look. And one other goal of this is to try to reduce the impact of any extreme low predicted values. So as we mentioned, the whole goal of this step of doing a risk adjustment to predict the spending is to take into account the variation of the case mix, and this is done by several factors such as age and illness, and a linear regression is used on all these various risk factors to try to assess the relationship between these different variables that each beneficiary has and what their standardized episode spending is. And this is done across all the hospitals in the country to get the standardized amount. This regression that is performed is done separately on each major diagnostic category. And so there's 5 main groups of risk factors for each patient that are used to calculate what the predicted spending is. First is age, separated into 12 different ranges. Second would be the disability and end-stage renal disease status, or this is the main reason that they're enrolled in Medicare. Third would be any recent use of long-term care, and fourth would be the MSPB of that index admission. And a final big set of factors that are used are the hierarchical condition categories. And these are 70 different indicators that are taken from the beneficiary's claims from that period 90 days before the start of the episode. And this basically puts them into these different bins of different health conditions. And as a one added part to this model that is used to calculate this predicted spending, they also include some statistical terms to model the interactions between those HCCs and the enrollment status. And it's important to note there are a couple of factors that are not included in the risk adjustment, and that is the beneficiary sex or race. And one really big component that's sometimes a little hard to both understand and explain is the attempt to try to reduce the impact of extreme low-cost predicted values. And one of the side effects of having such a large number of risk assessment factors that are used is that you're basically putting people into these bins, and by having such a large number of different variables, you end up with very few people in each bin, and this can cause some of them to have predicted values on the extreme bins. And CMS tries to help take care of this by a process known as winter rising. And this is simply where all the predicted spending values are put onto a normal curve, and we look at where is the 0.5 percentile. And all the values that fall below the 0.5 percentile will be reassigned to the value at the 0.5 percentile. And that's shown graphically here, where we have put the predicted episode spending amounts on this bell curve, and we can see that the 0.5 percentile is shown on the left, so that any of the values that fall in that gray shaded area will have to then be brought up to the 0.5 percentile. And I think as we go through our example later on, this will become a little bit clearer. Step 4 is to exclude the outliers. And so this is where we are trying to eliminate the impact of the hospital's episodes that have very extreme differences between the standardized spending that we calculated in step 2 versus the truncated predicted spending that we just did in step 3. So the statistical outliers are simply calculated as shown down here, is taking the standardized episode spending and subtracting the truncated predicted episode spending. And that gives us our what is called a residual. And so what we're looking for is these outliers that are on the both high cost end and the low cost end. The high cost is defined in any that are above the 99th percentile, and low cost is any that are below the first percentile. And we have this shown graphically again, where we have the distribution of the residuals, and you can see that there's, in this example, there's one episode that falls below the first percentile and one that falls above the 99th. So in this case, each of those would then be excluded totally from the subsequent MSPB calculations. The step 5 is the last big step, and this is where we are calculating the actual MSPB measure. So the goal of step 5 is to calculate the average standardized spending for the hospital, to calculate the average truncated predicted spending, and then use those two to calculate the average MSPB amount for each hospital. Combine that with the national median of the MSPB amount, and then use these to calculate the final MSPB measure. So getting the average standardized spending is a very simple usual calculation of an average, where we simply sum the standardized spending for all the hospital's episodes, divide that by the number of episodes. And the same basic calculation is then performed on the truncated predicted spending. And these two net values are then used to calculate the MSPB amount. So we then take the average standardized spending, divide that by the average truncated predicted spending, then we'll multiply that times the average spending that happened across all the hospitals in the country. That gives us our own hospital's MSPB amount, which then goes into the final equation, is using the MSPB amount to divide that by the national median MSPB amount that has been calculated for all the different hospitals, and that gives us our MSPB measure, which is the actual value that you have seen in your VBP reports. And I should emphasize that national median MSPB amount is weighted based on the number of episodes at each hospital. And now we will walk through a very brief example, and this page is just showing the set of data that we'll be using. You can see in column B we have a series of 8 different episodes, and these fall under 4 different major diagnostic categories. So to start with, we'll look at the standardized episode spending, and we'll just assume for the sake of this example that we already have done step 1, which is to figure out which episodes should count. So we start with the standardized episode spending, and that's shown in column C for all these 8 different episodes. The second is to look at the predicted episode spending. That's column D, and this is simply the values obtained for each of those episodes after the risk adjustment step was performed. Next is to do the winter rising that I had mentioned, and this is where we take all those hospitals' predicted episode spending from column D and look at where is the where is the 0.5 percentile of those. And you can see, as I mentioned, those are run separately for each of the major diagnostic categories. So you can see we have $1,000 for the first one here, and so we will then compare that 0.5 percentile in column E with the predicted spending that we calculated in column D, and basically see which of those is higher. So that then becomes the truncated predicted episode spending in column F. Okay, so now we're going to do our outlier step, and that is simply to subtract our standardized episode spending from column C, take that and subtract the truncated predicted episode spending in column F, and then we get our residuals, which are in column G. We will then compare those with the first percentile and 99th percentile of all the MSPB episodes. And you can see we have the first and 99th percentiles shown in columns H and I. And we take a look at those and see where our residuals in G stack up against those. And you can see for all of the episodes except for one, those residuals do fall between the first and 99th percentiles, except for episode number 6, which we show here in the pink. So that episode will then be excluded from the subsequent calculations. So now we're going to simply take the averages of the standardized episode spending in column C, and then we basically have the hospital average down there at the bottom in gray. Then we do the same thing for the truncated predicted episode spending. Then these two numbers are what we will use to get the hospital MSPB amount. And you can see the sample that we have here is shown. So we take basically column A, divide by column B, then we will multiply by the national average standardized episode spending, which is in column C, and that gives us our individual hospital's MSPB amount, which is in column D. And we have just one more step here, and that is to take the hospital MSPB amount in column D, divide that by the national median MSPB amount, which is in E, and that gives us our final MSPB measure, which is in column F. And for this specific hospital, that will be a 0.92. And we have a series of slides here after this example that we won't be actually going over, but we just wanted you to have these just as a reference for the steps we went through. So with that, I am going to hand it back to Sarah.
Great. Thank you, Eric. So as we reviewed before, the Medicare spending per beneficiary performance is used in calculating a hospital's total performance score for value-based purchasing. And when calculating the domain score, the hospital's performance is compared to the threshold, which is the mean of the lowest, the threshold, which is the median. I'm jumping ahead of myself there. The median MSPB across all hospitals during the performance period, and then also with the benchmark, which is the mean of the lowest decile of performance across all hospitals during the performance period. So there are a couple of things to note with regards to measure reporting. In order to reduce the likelihood that a hospital's MSPB measure would be affected by only a few high-cost outliers, MSPB is not calculated for hospitals with fewer than 25 episodes in the performance period. The methodology calculates MSPB for all hospitals with an episode during the performance period for use in the measure calculation, even if they're not a value-based purchasing eligible hospital, but for payment purposes and posting to Hospital Compare, only VBP eligible hospitals will receive a score. So now that we've reviewed what's entailed in calculating the MSPB measure, Eric walked you through the steps and an example. We want to think about how we can use this information to inform our performance improvement strategies. So to do that, let's take a look at the full timeline as it was described through the course of the presentation. In the center, we have the index admission, which is the time the patient is receiving care in the hospital. And obviously, there are implications for hospitals when thinking of ways to improve efficiency and cost reduction in delivering that inpatient care. At the same time, it's important that patients receive the appropriate amount of care before being discharged, considering the impact of claims that have a start date within the 30 days post-discharge. So during that post-discharge period, patients could be receiving care in primary care setting, long-term care, home health, readmissions to the same hospital or another inpatient facility. There's a lot to consider. and understanding the various factors at play and coordinating care through these transitions is essential to increasing efficiency as well as improving patient outcomes and experience. Regardless of whether a hospital is independent or part of a large health system, it is essential that there is clear and consistent communication with the patient and across settings of care after they have left the hospital. That same need for communication arises prior to the patient ever coming to the hospital, as the 3 days prior to the index admission are included in calculating the episode spending. Also, as Eric described, there are implications in the MSPB measurement with regards to risk adjustment that are dependent on the hierarchical condition categories, or HCCs, which are derived from patient claims during the period 90 days prior to the episode, which points to the importance of primary care in identifying and documenting medical concerns. During our next webinar, we'll share an analysis of regional data that will dig into what the primary drivers of costs are across this timeline. And in the third webinar of the series, we'll discuss some quality improvement strategies to address those drivers. We wanted to provide you with just a few of the resources that you might find useful, a few additional resources you may find useful and that we referenced in putting together today's presentation. So as we mentioned previously, Medicare Spending per Beneficiary first was introduced to value-based purchasing in fiscal year 2015, and you can find more about that initial introduction in the Inpatient Prospective Payment System Final Rule from 2012. There's also a link here to the CMS Medicare Spending per Beneficiary National Provider Call that was held in 2012, and that's actually where we got some of the data used in the example calculation that Eric walked you through today. And then the measure methodology reports for MSPB can be found on the QualityNet website. So with that, we would like to open up the line for questions. I don't know if there were any questions in chat during the time that we were here. We'll ask Ross to help us out with that, and then if we can provide instructions on how to ask questions over the phone, that would be great.
And hi, sir. This is Ross. We did not receive any questions regarding the content of the presentation. There was a question about the slides. So I posted the links in the chat box for all attendees to view. And if you have any issues accessing today's slides or the VBP fact sheet that is located on the LSQIN website, just let us know. And those will also be provided in an email after this presentation.
And we will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up your handset first before pressing the numbers. Once again, if you have a question, please press star 1.
Thank you.
And our first question comes from, there's no name recorded. Please announce yourself. Your line is now open.
Hi, thank you. Wondering if you could tell me, slide 35 talks about presence of certain comorbidities increase costs in a greater way than predicted by the HCC indicators alone. And the bullet point above it talks about how that model accounts for the interactions. Is there any way I can find out which comorbidities we're speaking about that would factor into the overall model?
Well, I can take a stab at this, and I know we do actually have a list of all the HCCs, and I believe the model that is accounting for the interactions is simply creating an interaction term of these various HCCs versus the disability and end-stage renal variables. So it's going to be the comorbidities that are rolled up into these HCCs. And I guess I can't speak to which ones are having the biggest effect, but I could certainly look I could certainly look into finding any documentation.
Thank you. That would be great. And that's exactly the direction I was going is once I was able to see if there's a list available,
right.
Figuring out which ones had the biggest impact, be it diabetes or heart failure, and just imagining what those might be.
Sure.
Thank you.
Oh, that's a great question. If you could, the last slide includes Eric and my email addresses, so if you could jot us an email so we know how to get back in touch with you, that would be fantastic.
Of course. Thanks. I'll be happy to do that.
Thank you.
And we have no further questions at this time.
Hi, Sarah. This is Ross. And that there's a similar, there's another question regarding the HCCs in the chat, and the question was the HCC model is usually based on year-to-date diagnoses on claims. Why does this model only include HCCs attached 90 days prior to the MSPB episode?
Well, I'll try to answer this one too, and I guess the simple fact is I can't necessarily speak to what CMS, what their thinking is exactly. I can only surmise that they're, I think, trying to have a limited, impact of, realizing, what impact can a hospital have on the data that's in the Part A and B claims that aren't their responsibility. So I think they probably just simply used the bulk of the HCC methodology and just limited that to the 90 days, just with an eye on an understanding of how much effect could a hospital have. I don't know if that fully answered it, but I don't know if Sarah, if you have any other ideas.
No, I was thinking the same thing, that it's probably just an attempt to place a limit on the period of time that they're considering, and pointing to the importance of primary care and managing some of those chronic conditions. Great question, though. Are there any other questions? Either you can post them in the chat box, or you can opt to ask them over the phone.
And once again, if you do have a question, please press *1. Sarah, it looks like there's no questions on my end.
Great, thank you. Well, again, I really want to drive home the importance that this was the first in our three-part series, and this was really getting into the nitty-gritty nuts and bolts of how is this measure calculated, so that we can better understand what the drivers are that would cause a hospital to maybe not perform as well as they would like to on MSPB, and then what are some ways that we can look at some quality improvement strategies around this particular measure. And so we really hope that you will join us for the second and the third webinars as well. Mark your calendars and get registered for those. Invite others from your organization who maybe weren't so interested in how MSPB is calculated, but would be involved in maybe driving some improvement efforts around them. As a reminder, a recording of today's event will be posted to the event page in the next couple of weeks, and we ask that you please take a few moments to complete the evaluation that will pop up when you close out of the WebEx. Upon completing that evaluation, you will receive a certificate of participation for today's event, and we will use your feedback to inform future educational offerings. So with that, we will wrap up just a little bit early and wish you all a wonderful afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.